Dr. Alvarez from FCI. So do you guys, I don't have anything specifically prepared. This is more of a question and answer kind of situation. If you had any questions from the previous talk or from any of the other talks.
I had two.
Yeah, go ahead.
My first one, is there a compounded risk with refreezing embryos from frozen eggs?
No. So when we thaw eggs and we fertilize them, the embryo is technically considered a fresh embryo. So when you freeze a fresh embryo from a frozen egg, it still has the same potential as if you came from a fresh egg, fertilized, then frozen.
And then my second question is, for the DNA testing of the egg donor, is it just genomic, or do they test mitochondrial DNA as well?
So are you talking about PGS testing, or are you talking about genetic screening for the donor?
Screening for the donor.
For genetic screening for the donor, we're screening for recessive disorders. So these are specific genes that are looked at. They wanted to see if they're a carrier of a specific disorder like cystic fibrosis or Fragile X syndrome, Duchenne muscular dystrophy. There's a whole list of recessive disorders that a donor can be a carrier for it. So if she's a carrier of that one disease, you would have to be tested because you both have to be carriers of the same disorder to have an affected child. That's what they're testing for.
So they don't test for any like mitochondrial disorders?
No.
Okay.
Yes, it's genomic.
Okay.
Can you talk a little bit about friends and family donors?
Yes, I do have several patients who use either a friend or one of their family members. They still go through the same process if they're going to be an egg donor or a surrogate. I meet with the donor, a known donor, do a physical exam, get their medical history, do an ovarian reserve testing with the pelvic ultrasound to look at how many follicles they have, the FSH level, the AMH level, to see if they're a good candidate. And then after I meet with that person, I will be in contact with you and let you know, do I think this person is a good candidate? And if not, why? And then you decide if you still want to move forward with that candidate.
Okay. And does egg donation versus that person's pregnancy history have any consideration? Is that?
It's age.
Okay, just age for the eggs.
Age for the eggs.
Okay.
The younger, the better.
Got it.
Because then you have more eggs, less chance of having an abnormal embryo, and therefore you have more viable embryos to be able to transfer. Versus the other couple where they had a 40-year-old donor with only 6 eggs, that's kind of a bad situation to be in.
And then for the frozen embryos that, so let's say there's one thought that, but then do they refreeze the others, or is that the first time they're frozen?
They're only frozen once, and then they're thawed once to be able to transfer. So we thaw one, there's a 99% thaw survival. So if that one doesn't survive, then we go to the next embryo. We don't thaw them all, transfer one, and then refreeze the rest. Yeah.
Does your practice, for the egg donors, do they have a decent amount of biracial egg donors as well as just Caucasian?
So the majority is Caucasian for the egg donors. In our database, we do have a few minorities, like African American, Hispanic, Asian. The majority are white. This is why sometimes the egg donor agencies might be a better source because they do have, they get nationally donors. And what we do, we try to do is get local donors. Yeah. What else?
What's your experience with if there is the parents decide they want a sibling? So usually they would draw from the frozen embryos that are still frozen from the first round, and then do they usually go with the same surrogate or a new surrogate? Or?
Yeah, so it depends if the surrogate is still available. So there are stipulations where a surrogate can't do more than 5 deliveries or more than 3 C-sections. So if your carrier met that criteria, she won't be able to be a surrogate again. But if I have couples where they've used the same surrogate twice, because she was still eligible and she still wanted to be a surrogate, and that would be up to the surrogate. Mm-hmm. Trying to think of any word of wisdom that I can give you guys. There is no right or wrong way to start. A lot of people start with the IVF clinic. A lot of people start with the surrogacy agency. A lot of people start shopping around egg donors, different agencies for egg donors, or even looking at the donor egg bank. So the donor egg bank probably has the largest selection, because they have more than 300 candidates in their database. So that's going to be the most wide if you wanted to find something that something more specific. People tend to use more of the fresh donors than the donor eggs, than the frozen eggs, because, like I said before, you only get a fraction of what that donor made. So about 6 to 8 eggs, 10% less chance of pregnancy with frozen eggs, and we think it's because we're only getting a fraction of those eggs. So with a fresh donor, what happens is that you get all of the eggs, and then you fertilize them all, and then you go all the way to day 5 of transfer, and then you transfer the best embryo out of there. But if you're only starting off with a third of that donor, you may not get to that good embryo, where if you had all of them and we had more embryos to select from, then that causes a higher chance of pregnancy. So I recommend doing fresh versus frozen eggs, but it's also a monetary thing. So frozen eggs are cheaper. They do have a guarantee where if you don't get at least one good quality embryo, or if you don't get a positive pregnancy test, you get another set of eggs free of charge. And then, if you want to have more than one child, and that one lot only yielded one embryo, then you would have to either see if that same donor still has more to be able to save, or if you're planning for baby number 2 and she's no longer available, then you're going to have to use a different donor. And I'm not sure, I don't know the answer to this question, but I don't know if you can, ahead of time, you would have to call the egg donor bank to see if, okay, we're going to use this donor. If we get a pregnancy, is there a way for us to pay for and save another lot for baby number 2? That would be a good question to ask the egg bank.
Do you have any comments on the known versus unknown, just in general experience?
Sometimes it's a little bit harder when it's known, because when we use a donor, only about 5% of all the donors that we screen actually become donors. So there are many reasons why a donor doesn't become a donor. Maybe their medical history, their ovarian reserve is not great. So when you have a specific person, and then they're not the best candidate, then that becomes a little tricky. Yeah. And then single versus double embryo transfer, as you guys have heard throughout the whole weekend, that all the REs always recommend one. And this echoes the recommendations from the American Society of Reproductive Medicine. They have a guideline of how many embryos to transfer. So by definition, all of the anonymous egg donors are good quality, good candidates. They're less than 35 years of age, and they're going to good prognosis. So because of that, they fall into the category where they should only be having a single embryo transfer. And Dr. Segal showed the slide where you really don't increase the chance of pregnancy by doing a double embryo transfer. You only double the chance of having twins. And like everybody was echoing, twin pregnancies are more complicated. Sometimes the gestational carrier has to be compensated more. She could end up in bed rest at 30 weeks or even earlier than that if she goes into preterm labor. Then again, preterm delivery of babies, babies ending up in the neonatal intensive care unit. So for all those reasons, we always recommend one at a time.
If you do a double embryo compared to a single that splits and becomes twins, are the risk for the pregnancy still basically the exact same?
Yes, they are. And it's about a 1% chance of an embryo splitting. Yeah. So not too high.
Are the egg donors screened for like family history of twins, or is that just
It just happens, and and we think that it's through the process of IVF. when we're doing the assisted hatching, when we break the zona pellucida, or we're doing the ICSI procedure, that may cause splitting of the embryo. So it's not. We're not seeing that it was because the egg donor had a family history of identical twins. And then for the surrogate, also age is also a factor. So any surrogate that's older than 40 years of age, they have all the complications that come with aging. So high blood pressure, diabetes. So choosing a young surrogate is also ideal, less than 40, and then for the donor, less than 30.
Has there been like there's like the 23andMe genetics thing? Is there any changes to this world from that? Like,
no, and we don't use the results from 23andMe because those tests are not verified. The only tests that we do are the genetic screening for the recessive disorders. That's kind of not new, but that's something that we do, and then PGS testing on pre-implantation genetic screening of embryos. And then you also should know that only because an embryo was genetically normal, it doesn't mean that it's going to be 100% normal pregnancy, because we're not screening for disorders in the embryo. We're only checking to see, does this embryo has 46 copies of their chromosomes, yes or no? Not does this embryo have a higher risk of having diabetes or high blood pressure or other medical conditions.
For the pre-screening, are your genetic counselors in-house?
We do not. And many clinics don't have genetic counselors. There's the national shortage of genetic counselors. The labs that we use, like Natera and Good Start, if anything comes back abnormal, they have their own genetic counselors that will call you and do an in-phone genetic consultation to let you know what the results are, what do they mean, and what does it mean for your future offspring. And then there's also a whole slew of genetic screening. So there's a panel where you only are screening for 22 diseases, and then there's other ones that are looking at 200 or more diseases. My own personal philosophy is that I like to only check for the most common disorders, because everything else is like so super rare, usually more expensive to do the expanded carrier status, and if the surrogate or the egg donor is positive for one of those rare diseases, then you have to go through the whole testing as well, because you want to make sure that you don't have, even though if it's rare, you want to make sure that you don't have it so that you don't have an affected child. So some of the clinics where they're offering these very long, expanded 200 plus genes, it's not very cost effective in my personal opinion. I like to do more of the 22 genes that are more common. All right, that's all the time we have for. Again, if you guys wanted to come see me in clinic, there's a phone number you can call to make an appointment to come see me. All right, thank you.